Well, maybe I should go back a little bit. When I was in medical school, I really enjoyed cardiology, and as a cardiologist, there was, different specialties. I could have been a plumber. I could have done cardiac caths and angioplasties and done interventional cardiology. But, something about heart rhythm problems really did something for me because I was a musician, actually, played guitar, some drums and piano. So, understanding and being able to see arrhythmias on an EKG became very natural to me. So, I decided to do electrophysiology, and I finished my training in 1987, I believe. So I've been practicing electrophysiology ever since.
And so, did you find that you were able to grasp the whole concept of reading ECGs a little easier than some of your classmates because of your musical background, or
I think so, but it just was a challenge to me to the point where I really wanted to become an expert in it, and so I really spent a lot of time doing it. In fact, when I was a fellow, I was moonlighting at Jacobi Hospital, reading EKGs for the hospital, and as a resident, I was responsible for reading EKGs as well. So I had a lot of practice before I went into cardiology, and I just love it. It's the world that I live in, and what was really frustrating to me though is as an EP doctor walking around the hospital, looking charts, and I would constantly open up a chart and look at the rhythm strips that were documented by the nurses, and I could always find something that was mislabeled, and it was very frustrating to me. There was this immense lack of expertise. Even today, most nurses and telemetry techs and even a lot of doctors are functioning at a very basic level when it comes to electrocardiography. So, I mean, that's actually why I decided to initially create some videos and put them on YouTube. I wanted to bring my expertise, my electrophysiology approach to ECGs. And back in, I guess, 1990 or so, um, was it that far back? Let me think about this. No, it was around 2010. I started to put ECGs on YouTube. These lessons and chalk talks especially. I would take an
right?
unknown strip and kind of go through it step by step. Like, what should you be looking for? What did you miss? What? How does an electrophysiologist approach this thing?
Right.
And they really caught on.
I can see why. I mean, they're proud. I mean, what was available in the market at the time?
Not much. In fact, I think that's kind of why my YouTube Chalk Talks were really well received. I was getting so many positive comments. People were like, wow, this is great. Please keep them coming. And then I realized there was this really incredible need for this sort of like expert take
Hmm.
on arrhythmias.
One thing that surprised me on your channel is that I looked to see what your most popular videos were, and I think it was about 11 years old, and it was just placing the leads at about a 500,000 views. And you would think that is like, isn't that like the most basic of the basic?
Yeah, yeah.
Yet that's such a highly watched and valued video.
Well, I put like a lot of how-to videos on there, and then I decided to create a full-blown sort of a, f- a course, a formal course in electrocardiography, taking it from like the basics, like what is electricity, how do ECG machines work, and like how do you hook up a patient, and what should you be looking for, and how do you measure the intervals,
Hmm.
and those first few topics kind of went on YouTube for free for anybody to watch, and they've really been very popular.
Well, they deliver a lot of value. I mean, even for like a layman like myself to watch those basic chalk talks, I actually feel like I learned something each one. Even though I don't have the cardiology and I've been out of nursing like 25 years, I mean, it's highly interesting to me, and I'm always interested by that stuff. And your videos are laid out very well. I guess, I mean, you're really one of the earlier people on YouTube doing certainly cardiology.
Yeah, and the way I did it, it wasn't like me standing in front of a whiteboard, and a lot of the quality is missing in many of the other videos that you'll find on YouTube. I wanted to make it the highest quality, something so clear that everybody can see even the tiny details, because I mean, honestly, that's where the answer lies, is in the nuances, the tiny, subtle details that most people miss. And
Yeah.
so people who go on ecgacademy.com and take my course, well, I teach, it's almost like, I do the videos as if you and I were just like sitting having lunch, and I pull out a pad and a bunch of markers, and I just sort of draw and then kind of focus on what's important and what gives you the right answer every time.
It really brought me back to when I was a student nurse and we were struggling with a real patient. We, on the floor the first time, and this kindly older doctor came by and he like walked me through an ECG, and I was like, I just felt that again when I came across your lectures. Can I just show 2 minutes of one
Sure.
of your chalk talks
Sure. That'd be
so that
terrific.
people, yeah, so I think this is a really good example of showing your step-by-step thinking and pattern recognition, and then how you so elegantly explain it with such simple tools. So let's have a look at that.
We're seeing just a short PR interval, but here's the trick. You really shouldn't just look at this. You really have to look at the whole thing. Because if you kind of glance at the baseline between these QRS complexes, there's a hint here. Because in front of this little bump here that you think is a P wave, there's a flat segment, but it's not exactly flat, is it? It's kind of slanted. It has a slope to it. So when you think about slopey things, what you need to think about are sawtooth waves. What does a sawtooth wave tell you? Atrial flutter. Now, how do you know it's atrial flutter? Well, if you look really closely, behind this bump, there's actually another bump that looks just like it, right there. And if I take out my teeny weeny calipers and bring them on over, you can see that, well, my marks got in the way of that one. Let's measure these over here. You have these two, which are a little bit slower than 300 beats per minute, probably about 275 beats per minute. And then if you measure on over, you see that there's actually a bump on the very beginning portion of the T wave. And so if you put your caliper lines on that, then you're reading the end of the T wave. And if you measure out after that, you see the next bump here, which is a flutter wave, occurs on time.
Well, that was great. I mean, you can't read ECGs without these, can you? Realistic.
I can, because I've trained my eyes to look at
Right.
things, and you can too. You can literally train your
With
eyes
enough practice.
with enough
Yeah.
practice, you won't need calipers. But that's part of the whole mystery of ECGs, is how do you use calipers properly, and that's sort of like I introduced that early on in the whole experience.
Right. Yeah, I
It's
bought
funny,
these.
you talked about the old doctor, the kindly old doctor. Well, when I was a medical student, in fact, the summer between my first and second year, I decided to do an elective in cardiology, and that's where my passion for cardiograms came in, because I worked with a cardiologist up in Syracuse,
Mhm.
that summer. And we used to go to the ECG reading room. There was like this dark room with lights, and with it. And he would have a stack of cardiograms like this, like 100 of them, and he'd hand me 10, and he'd say, "Here, what do you think?" And that's how I learned how to read them, because he would show me what I was doing wrong, and
Mhm.
that's what you really need to do, is have someone show you, the right way to read them and how not to miss things.
Well, it's like you found a way to sort of deliver at scale mentoring through
Yeah.
YouTube. Like mentoring is really something we've starting to lose as a society, and it's great to see programs such as yours. And your course qualifies as, in Canada, we call them continuing education credits that doctors and nurses are required and paramedics. So your course meets the requirements for that in the United States?
Yeah, it does for nurse practitioners, for physician's assistants, and also RNs can take it. And I'm an accredited CE provider for nurses as well. Some techs can use my certificate to provide proof of continuing education as well.
That's wonderful. So everyone in the world has an ECG on their wrist now. Good or bad?
Me too. You
Yeah.
know,
But you're the pro. You're supposed to have one.
Well, yeah, and I think that there's the future of medicine is patients getting involved in their own care and not sort of relying on the once every 3 month going to the doctor and having their blood pressure checked. I mean, when I'm taking care of a patient with hypertension, I'm the first one to say, go buy yourself a blood pressure cuff.
Yeah.
So you can keep an eye, because you can keep track of it. And I show them how to use it and everything. The same thing with arrhythmias. I mean, a lot of people will use their watch or their Fitbit or whatever to record heart rates. Now, heart rates can be deceptive because sometimes it may not be accurate, but it doesn't tell you what the rhythm is doing. But what the devices nowadays will actually let you record your own electrocardiogram. And that's amazing. I mean, we couldn't do that 10 years ago.
What surprises me more than that is in the US, patients are actually emailing it to their doctor, and their doctors actually answering the email, because that would never happen here in Canada. And every time someone tells me that, I'm just blown away, because that would just never happen here.
No,
I mean,
I don't do that because it's too much of a liability.
right.
What if,
Well, it's their patient, to be fair. It's their patient, right? But
exactly. But to have a patient send me an EKG that looks like a heart attack or something, but it is
what are you
very,
going to do?
But certainly very useful to record arrhythmias. You know what? It turns out the data shows that there's a poor correlation between between symptoms and arrhythmia. I mean, there are patients when they were monitored for weeks at a time, and when they thought they were in atrial fibrillation, it turns out it wasn't. And at other times they were in atrial fibrillation and they didn't have any symptoms. So the correlation isn't good. So having it on paper, having a picture of your ECG at the time of your symptoms is very valuable for the doctor.
Yeah, empirical. Doctors will go for empirical evidence every single time, right? So,
right. And, sometimes doctors get annoyed when people bring them recordings, but I love it because I can go over it with the patient and show them what they should be looking for. Some patients are pretty savvy with it, and others, they just don't know what they're looking at, because in fact, these recording devices are not entirely, accurate, because you can get a lot of noise introduced if you're like touching your watch and your hand is moving, or your fingers, not making good contact. You can get all sorts of wacky, squiggly looking stuff, and then people go, "Oh my God, I'm having a heart attack," but it's not. It's just artifact.
Yeah, I mean, I often share the story of, before I go into AFib, I would always say to my cardiologist, I would go into something first, and it becomes AFib, but I know it's not AFib. And then when it transitioned to AFib, I feel like there's a fish flopping in my chest, and then bang, I'm in AFib. And it would follow this pattern. So I bought the ECG, and then, stupid me, I went and did all this lifestyle stuff and stopped having the AFib. So I was never able to catch it. And then August last year, got lucky, I guess. I was in the shower and I felt it. And so I managed to catch it on the ECG. And it turns out I start in a flutter. And when I went to the surgeon, he said, "That's great. Now I know exactly what to do in the ablation." So I feel like, for me, it's been a plus to have that, because I would have had to wear a Holter for 2 years for them to catch that.
Well, I always say that I would be the most successful cardiologist in the world if I just bought about 1,000 Holter monitors. Right. And every time a patient would come in my office, I would put it on and say, "Here, put this on and leave it on, because as long as you're wearing this, nothing will happen."
Yeah. And But we're seeing those enter the market now. There's actually one you can buy for, and their angle is for fitness, because I guess they don't want the liability of saying anything else. But it is a continuous ECG, and it looks like a heart rate chest strap that you wear
Mhm.
in the gym. But it claims to keep a continuous ECG, and it's really cardiac people buying them. I mean,
Yeah.
marathon runners don't need it,
That's
right? Yeah,
technologically not difficult to record the ECG. What's hard is to interpret it and decide what to do with it. Because treating atrial fibrillation isn't easy.
right.
A lot of primary care doctors think they can manage it, but the American College of Cardiology and the American Heart Association guidelines for the management of atrial fibrillation, it's like 100 pages long.
Yeah,
Because there's not one way to take care of it. It is very highly variable, depending upon what's actually going on. Think of atrial fibrillation as not a disease but a symptom, and it may be due to any number of underlying physiological problems. So the specialists like myself, electrophysiology, that's sort of like the cream of the crop. When the cardiologist doesn't know what to do, he sends the patient to the electrophysiologist. I mean, I never treat the same patient. I mean, the two patients the same way. It's always take the patient's history and their underlying condition and their other medications into consideration before I make a recommendation.
right. I think one of the challenges that family physicians have, and just going by anecdotal tales of AFib patients who have been on my show, and there seems to be this common pattern of where they've had what they thought was anxiety later blossomed into AFib. And so I can just imagine these poor family doctors. Well, we'll give you an EKG in the office. It didn't show anything. I mean, because you can provide too much care and do harm that way too, right? So what? And there also is this mix, I guess, of doctors who like take AFib really seriously, send them right off to the cardiologist, and then there's another family of doctors like, it's no big deal. It's just so. I mean, what can community medicine do better in your mind? And where are they good? Like, where do they deserve credit?
Well, I think primary care physicians have a good relationship with their patients. They know their patients well. Um, Often, when you go to a cardiologist, cardiologists have been unfortunately under a lot of pressure because not only is their reimbursement lower than it used to be, so they have to spend less time with each patient, but electronic medical records, that's like a sinkhole for time and energy because you wind up spending half of your time in front of your computer actually typing. It's a good thing my mother
Mm-hmm.
was a secretary because I learned how to
Yeah,
type with 10 fingers. And I mean, otherwise, it would take me forever. So cardiologists maybe not, they don't spend as much time. That's where the primary care physician might, have a better relationship and can understand the nuances of the patient's symptoms and what other problems need to be treated. But in
right,
reality, there are a lot of decisions that need to be made, in terms of whether to try to control the patient's rate or whether to get their rhythm back to normal, whether they need to be on blood thinners. I mean, those are not easy questions to answer, and that's where it may be better for patients to see a specialist who's used to dealing with the problem all the time.
right, right. And I imagine some of that reluctance to refer, maybe perhaps the patient doesn't have the healthcare coverage. This is factored into the decision, and that's certainly understandable. The family doctors, well, I'll do the best I can for you in this case, right? And that's the reality of the world.
Well,
So
it is. Although here in the States, usually if you have any kind of insurance, you can get in to see a cardiologist pretty
right.
quickly, except in New Jersey. You know what I'm talking about? New Jersey, people got to wait a couple of months. It's like, hey, what are
Right.
you talking about? I got problems now. Know what I
Yeah.
mean?
Well, come on to Ontario. I'm on the 1 year waiting list for an ablation. So
Oh, oh
come
boy,
on. Yeah, come on.
I could I could do one on Monday if you want.
Yeah. If we can get Trudeau to pay for it, I'll be right there.
Okay. No, it's
Yeah.
actually ablation is a really exciting field because there's some major changes coming down the pike. I
Okay.
don't know if anyone has any interest in it, learning about that.
Absolutely.
Yeah,
We're all
because
about that. Yeah.
well, it turns out we learned probably 20 years ago that much of atrial fibrillation, maybe 80 or 90% of it, originates from the veins that lead from the lungs to the left atrium. There's four veins in the back of the left atrium, and inside those veins are abnormal cells that start firing and they trigger atrial fibrillation in 80 or 90% of patients.
Right.
So ablation procedures have, for the most part, evolved, and the target are those veins. And the idea is if you can create like a wall around those veins
Yeah.
that
Scar tissue.
of scar tissue, right? It's like a speed bump, so that the vein can go into AFib, but the signal can't get out to the rest of the heart.
Right.
So that terminology is called pulmonary vein isolation, and it's sort of the basis of most AFib ablation procedures now. The
Right.
problem is that the energy that we use nowadays, most of the time we either use electrical energy delivered with a little catheter that heats up the tissue, so you get this little pea-sized burn. But then you have to move it like 2 millimeters and make another burn, and move it 2 millimeters, make another burn, and encircle the vein with this
Not very
sort of
clean.
string of pearls, so to speak. And it's very tedious. And the success rate, unfortunately, isn't that great. It may be only, 70 or 75 or 80% at best, in the ideal patients. And then, but the new technique that's coming out, you can ask your doctors about it. It's called pulse electrical field, or pulse field ablation, PFA.
Yeah.
And there's like three companies that have developed the systems. And in the States, at least, we're waiting for the FDA approval, which kind of expecting by the first of the year. Now, what those new systems will provide is a very brief electrical field of shock, almost, that electrically disables all the cells around the veins without actually delivering any injurious thermal energy. So
Interesting.
it leaves the vein and the underlying muscular architecture intact, but is extremely effective at damaging the electrical characteristics of the tissue. And so, we're taking a 4 or a 5 hour procedure, and we can do it in 1 hour. And the success rate appears to be much higher, with a much lower risk of complications.
So pulse field. What form of energy is that using? Like magnetic or
No, it's electrical energy.
just pure electrical?
It's like the catheter looks like a little flower with multiple electrodes, and
Okay.
you deliver an electrical jolt, essentially, like in the terms of like milliseconds. But that electrical field that's delivered to the cells, basically, there's a word we call electroporation, where the cell membranes are very sensitive to that, and it literally punches holes in the cell membrane, but only of the electrically active cells. The fibrous cells and the muscular cells underneath are relatively immune to this energy and are not damaged.
So it's tissue specific. It's very tissue specific.
It
That's
is.
really interesting.
That's what
Let me
makes it safer.
let me take a moment. There's probably some people that are new to the chat world, but you can chat. And if you're watching this on Facebook or YouTube, if you throw it in the chat, we see it. Happy to answer your questions. There's a lot of you watching, so we're hoping to interact with you all a bit tonight. And I'm excited because Dr. Nick, you're the first doctor on my channel. So help me. Thank you for breaking that milestone in my minor YouTube career.
My pleasure.
Much appreciated.
Yeah.
And so that's interesting. So I imagine people are just chomping at the bit for this to get some approval. And
Absolutely. It's really going to be a game changer. It's revolutionary, and the last revolution we had was about 10 years ago, when the ablation catheters themselves were developed with contact force sensors. So we can actually tell how much force we are putting on the tissue. But that was 10 years ago or more.
Did you steal that from video game technology?
That's right.
Yeah, that's great. Coming back to the ECG world now, a Holter monitor. Like I've worn these things for up to a week, and then I get the results in my appointment a day later. So how does that happen? How does a week's worth of data get analyzed, and then the doctor feels confident in presenting me the results?
Well,
What's the
by the way,
process?
do you know where the name Holter monitor came from?
No, I don't. Let's
All right,
hear
the
it.
guy who invented it was named Norman Holter.
Okay.
He was a bioengineer, and what he developed was a way to transmit the ECG over radio waves. So the patient would wear a backpack, literally like a 35-pound transmitter,
Right.
and they would be able to receive his ECG remotely. So that was the first Holter monitor. But the what we mean by Holter monitor now is basically a recording system that records every single beat for 24 hour, 40, 72 hours, maybe a week. Like this, some patch systems will record every single beat, and then they're just basically scanned at very, very high speed and
Right.
analyzed by a computer most of the time, with a sort of a technician overreading it. Now that's
Right.
different from an event monitor. So event monitors don't record every single beat. They only record events.
Right.
So they're constantly analyzing the rhythm. And if they see something too fast or too slow, or if it sees something abnormal, it will record a picture. And sometimes these systems have like a cell phone that will transmit that recording, off to the company. So the
Right.
company will accumulate this whole, sort of like portfolio of recordings. And then, often the doctor will get a fax and say, "Oh, your patient had,
Okay.
atrial fibrillation last night," and then we'll see it and we'll be able to call the patient if we have to.
Interesting. Thank you for that. Miguel, I'm sorry I pronounced your name wrong, but thank you very much. Thank you so much for the information. Great job, gentlemen. Respect. Yeah, thank you very much. We're happy to have you tune in too. Yeah, for sure. I mean, I'm a fan of artificial intelligence, right? And when I crank out a video and I want to create the subtitles and I want a transcript, I let AI do it. So I thought with the Holters, there's probably some AI at this point getting into the ECG reading game. Where do you feel that's all going?
Well, electronic computer readings of electrocardiograms have been around for a long, long time. I mean, for decades. But there always has to be a cardiologist that overreads it. And I can tell you, as someone who reads hundreds of cardiograms every week, there's not one that goes by that's like perfect unless it's like completely normal. I almost
Right.
always have to make a little minor edit or do something. And, it's just the signals that you're looking at are so difficult for a computer to analyze in a matter of bits, and try to pull out patterns and try to extrapolate what it thinks is going on. I don't know. I don't see AI being any better than a skilled electrocardiographer or an EP. Certainly, I catch a lot of cardiologists who actually miss things on cardiograms.
Right.
So there's a lot to it. There's much more nuance than I think
Yeah.
AI is capable of really analyzing.
I always see the AI always because I use it so much, both at work and in my hobby. It's an augmenter of human talent. And it's actually, if you understand it that way, it's extremely powerful. So whether or not it replaces people one day, who's to say? But I mean, depends what movies you like, right? So
Well,
yeah.
there have been movies. I remember when I was a kid, I saw this movie called Colossus: The Forbin Project, and it was a very scary premonition of what could happen.
I'm gonna have to check that out. That has me interested. I'm a fan of classic sci-fi. So why
It was,
why do new students struggle so much with ECGs?
I'll tell you why. And this is the analogy I came up with. It's learning ECGs is like learning a foreign language. Okay, you can't learn it in one day. You can't open up a book and learn Spanish because then you'll walk around saying "Cómo está usted?" You have to have not only learn it in small bites, but understand what's actually going on, understand kind of like the words and phrases that you'll see on a cardiogram. And
Mhm.
that's what I tried to do with my course, is show people, the language of arrhythmias, and be able to analyze the tracing. Now, how do you do that? It's not really understanding the physiology. Like, how does the electrical system of the heart work? I mean, as an electrophysiologist, that's sort of a part of my life, and that's what I tried to get across to people. Is if you understand the why behind the tracings, it becomes much easier to analyze something that you've never seen before. And the
Right.
truth is that most electrocardiograms don't look like the textbook.
Yeah.
So being able to analyze something that you've never seen before is an immensely important and valuable tool.
Like I just Google AFib ECG and Google images, and I'll have such a smattering of different looking images that don't even resent. I mean, to my layman eyes, they don't even look like we're looking at the same arrhythmia.
Yeah.
So I imagine it can be wonderfully simply and hopelessly complex at the same time. So
Well,
yeah,
that's why I love it. I honestly love it. I mean, I'm passionate about ECGs. When I'm in the hospital and one of the residents comes up to me and they say, what do you think of this? I'm just like, ooh, give it to me. Let me show. In fact, I
yeah,
did CCU rounds earlier this week, and I literally spent an hour, going over like two ECGs to show them, what they've had these misconceptions about it.
right.
That's the thing. A lot of people just never spent time with an expert like myself, and they just walk around with a very primitive understanding of the whole thing.
Sounds like you're sort of paying it forward and remembering when you were in their shoes as well. And someone came
Exactly.
at you with 10 ECGs and said, let's go through these, right? Let's, before you tackle that live patient, let's make sure you got these right, you know?
and
So,
and I remember when I was a resident, I had a patient in the coronary care unit, and there was a very abnormal fast ECG, and I kind of like, I sort of struggled with it, and I took care of the patient. And the next morning, the attending comes on rounds, and he says, "What do you think of this?" And I was like, "Well, I think it's this." And he's like, "It's VTAC." And I was just like, "Oh my god, I can't believe that I missed that."
yeah.
And those sort of like aha moments, those epiphanies, or what form a person, their whole life. And that was what made me say, okay, that's it. I want to be an expert in this. I don't want to make that
Yeah.
mistake again.
Yeah. Yeah. No, I get it. I get it. And it's, is it a bit of a case of feeling you could be good at this, so you're naturally drawn to go that way?
Yeah. Yeah,
Yeah.
exactly.
Do you do, or I imagine you have, but do you still do like ER duties?
Not so much in the ER, but I'll get called as a consultant. Somebody who comes in with a fainting spell. That's kind of one of my specialties. Or
Yeah.
someone comes in with atrial fibrillation. That's the thing. AFib is such a common diagnosis, that the ER staff, they're sort of used to dealing with it. And from the patient standpoint, it can be extraordinarily scary. And yet everybody around you seems to be very laissez-faire. They're very sort of like, oh, we'll give you a little cardizem. We'll see how it goes. We'll call a
Yeah.
cardiologist.
That was
And
my experience. I mean, I was freaked. I thought I was having a heart attack. The ambulance was calling the doctor, and if we have to do a code, can we do a code? And I was like, I know what that means. I know what you're asking right now. So by the time I got there, I was scared. But everyone, once they hooked me on the ECG and they're like, it's AFib, everyone just relaxed. Like, okay, it's another AFibber. Like, it was so routine for them.
Mhm.
And, but I
Not for
left
you, though.
traumatized. I admit it. I actually had trauma after that. I had a lot of anxiety.
Mhm.
And I think looking back, the worst thing was that monitor, the ECG, and the alarm going off, beep beep, like so loud and so frequently. I think,
Mhm.
we talk about shell shocked. I get shell shocked when I hear that now, because it can be quite traumatic. So,
Definitely.
um, Yeah. So someone comes in, my heart's acting funny. I mean, what's like just a basic ideal triage process?
Well, it's hard to say, but of course, the first thing someone will do is take their pulse, check their blood pressure, and if their pulse is normal, they may go ahead and do an electrocardiogram just to see if there's something going on, if there's some sign that maybe there's a blood flow problem, like a
Right.
blockage or something. Uh, but most of the time, the history is so important. If somebody says to me, "My heart feels funny," well, what do you mean by that? Well,
Yeah.
how could you describe it? Is it feel this or that? Is it you having pain? What kind of pain is it? Is it burning? Is it stabbing? Is it pressure? Is it radiate? Does it go here? Go there? So the history taking is another dying art, unfortunately. Because the doctors who are in training today, unfortunately, have gotten used to relying on tests.
Right.
Instead of listening with a stethoscope, they'll order an echocardiogram,
Yeah. Yeah.
and that is so unfortunate because the history and physical will give you the answer, a good part of the time.
Yeah. I mean, it's true. I mean, everyone's more rushed these days. And the example I like to cling to is I've had a lot of doctors over the years tell me to lose weight, but they never weigh me when I come into the office. And I know that you get what you measure, and that doctors weighing their patient increases their chance of weight loss by 50%. If they know every time they see their doctor, they're going to be put on the scale, they double their chances of weight loss. Yet no one weighs you. My old doctor, when I was a kid, used to weigh me every visit, and
Mhm.
you don't see that anymore. Um, I guess it's just a sign of the times. I mean, there's more patients. We're living longer, but we have more problems that we're surviving through them to have more problems, right? So it's, I guess, a good problem to have.
Well, atrial fibrillation is, a problem of the older population. The prevalence goes up with each decade, and it's an enormously common issue. And as people are living into their 80s, you have like 20% of patients will have it of some form or another.
Right, right. Yeah, I'm always a fan of pointing out people are unaware that Joe Biden has AFib and he's had it for like 30 years, right? And he's just keeps on going. I mean, good for him, man. He became president with AFib. So what can you do? Why are you letting it stop you? You can become
Yeah.
president with AFib. Why not? Do you how many patients are successful though in improving their AFib with lifestyle based on your personal experience?
I think that it all depends on where the AFib came from. What's the physiology of it? I mean, if I have, a 62-year-old fellow who's overweight and he's hypertensive and he's diabetic, um, those are all predisposing factors. I mean,
Right.
each of those increases the risk of developing atrial fibrillation. They also increase the risk of a stroke and heart attacks and everything else. So those are, risk modification strategies that we have to implement in virtually every patient, whether they have AFib or not. But it definitely helps the reduce AFib. I have patients who, got their blood pressure under control. They, lost weight. They started eating right, and they're much, much better off.
Yeah.
You
No,
know,
I guess if you have a lot of obvious underlying causes, then the obvious approach is to tackle them,
right?
right?
That's the
Oh,
first
being
step often.
overweight. Yeah.
Before you start thinking about, oh, what medication should I put them on? I mean, the first conversation should be, we got to get your blood pressure under control. 160 over 95 isn't good.
No.
And when they look at to see how much their valves are leaking and how stretched out their atrial size is, and kind of better idea of how to treat the whole patient and not just treat the ECG.
Right. So, doctor, I mean, well, one thing that surprised me in your email today is that there's this thing called a telemetry technician. So is that an add-on to a professional license already, or is this a standalone profession of some sort? What's happening with
It's a
that?
standalone profession, and in fact, most hospitals and mentioned the event monitors and Holter monitors. So the company that provides those monitors will hire people to read them.
Okay.
And hospitals will have a whole staff of people who will like literally sit and watch the monitors and document rhythm problems. And often any patient who's like hooked up to a monitor, uh, those signals are brought to like a central station where
Okay.
one technician could watch like 40 patients.
Wow.
And they'll often have like 100 people they're being monitored by these technicians. So they need to be um, well versed in diagnosing arrhythmias. And then, if they see something, they'll often call the nurse.
Right.
And the nurse may contact the doctor. Um, most of the time they're right, but that's, not always. So, yeah.
And this is a career that someone can go to your ECG Academy online and get how long towards being able to practice?
Well, even the level one course that I offer, which is 14 hours of continuing education credit, that will allow a person to actually apply for that job.
Wow.
In fact, I had a transport aide at Emory University who like emailed me and said, what do I need to do to become a telemetry tech? And so I said, take this course. He did really well. And in
Yeah.
fact, he applied for the job. And the person who interviewed him called me and said, this guy was the only person that ever got 100 on the screening
Wow.
test that we provide.
Wow.
And he's doing really well in that position right now. So that's why I think a lot of people are in that position, but they're, they maybe read a book or they took a little course and they're functioning at a kind of a basic level.
Yeah. I mean, I took my stab at it and didn't go so well, but I'm just a video. I think a lot of us are more visual auditory learners versus a book, especially for something like you said, it's a language.
Mm-hmm.
Like you can't learn French from a book. You have to hear it and you have to speak it a bit. And if you can surround yourself with two or three other French people, or just like I used to watch when I was trying to learn Spanish, I'd watch movies in Spanish with English subtitles,
Mm-hmm.
just out of habit. If there was ever a Spanish soundtrack available, I would watch it
Mm-hmm.
in the Spanish version with the English subtitles. So I think that's the kind of training you're able to deliver through your online courses. So it's truly a wonderful thing.
Thank you.
So
I mean, that's what I
yeah.
try to do is get people to think like me. And, I
Right.
will start with a strip and say, well, what's the first thing you should look for? Oh, what do you think that is? And, well, these are the things it could be. And then sort of like take it step by step by step, until I finish the whole tracing. So, I mean, I think I found that's a very effective way to teach, and most people who have gone through the course have been very happy with it.
Wonderful. So they can find you at the ecgacademy.com if anyone is interested. If anyone's like, that sounds like something I want to do, you can check out the ecgacademy.com, join his mailing list, and there's an introductory course you sent out today that it'd be a good way to sort of test the waters to see if you have the aptitude, I think.
Yeah, you can
Yeah.
sign up for a free 2-month membership, and you can watch like the first 5 or 6 sections and see if you enjoy my teaching style and take it from there.
Is there a point where you get sort of for the advanced people, you get like collaborative with them and hands-on?
Well, that's a good question. There was a time when I was doing live streams on a Saturday morning, and then I've done a number of master classes. I think interacting is really helpful. So what I'm
Right.
trying to do is this year, I just revised my course. I re-edited every video, and I'm changing the way the quizzes are set up, and spending a lot of time just upgrading stuff. But I want to try to find some time to offer master classes to kind of like the upper level, people in the at the expert level. So it's for people to really kind of learn like the nitty gritty, like real advanced concepts.
Yeah, no, that's great. And so, man, where do you find the time to do all? Like for me, video editing takes a long. I find it's very time consuming. Where do you find time to I'll just re-edit all my courses, and you're a practicing cardiologist.
Yeah, it's hard. I mean, because I'm in full time practice, so if
Yeah,
I get home at 6 or 7 o'clock, fortunately, my kids are grown now. So my baby's 21 and she's off, in film school. So
yeah, yeah. I mean, I guess that helps, right? So, um, how have you found like on your YouTube channel? Do you actually get a lot of laymen watching? Do you find you get feedback from laymen?
I do. A lot of people have said, "Wow, this is really great. Thank you very much." Because some of the topics that I've done in the past, like some of my master classes are like how to avoid a pacemaker, or do you really
Right.
need to be on blood thinners if you have atrial fibrillation? And it's sort of an informational discussion so that people can take that information and bring it to their doctor and have a logical discussion. I try not to give medical advice for obvious
Absolutely.
reasons,
Yeah.
but I had a lot of comments on people. It's like, wow, this is really great. Thank you very much for that. So it's fun.
When it comes to working with people with AFib, because that's what my channel is all about, what's the most frustrating cases? I mean, I give you an example from my world. It's these guys who do everything right, and they get AFib at 30. They've been
Mm,
doing everything right,
mm,
and they don't seem to be. They can't get on a bike and ride an hour a day because they're already doing that, and
mhm,
they can't lose weight. They're already trim and fit. Like,
mhm.
what for you is the most frustrating?
Honestly, there's so much we don't know. But when you have a person who's healthy like that and they get AFib, it's almost always genetic.
Yeah.
They'll often say, "Yeah, my mother had it. My father has a pacemaker." There's there are you can inherit the tendency towards doing that. Um, so unfortunately, you kind of have to. You can't change your genes, unless you go to the laundry and do it that way. But you can't reprogram your DNA, is what I mean to say. So,
Is there an AFib gene? Did they discover a possible AFib gene?
well, it's not an AFib gene, um, but it certainly the tendency towards AFib can be inherited.
Right.
We don't understand why, and it may certainly be something about cell to cell connections. There's a huge amount of data to suggest that the nervous system, particularly the autonomic nervous system, has a profound effect on the atrium. In particular, if the vagus nerve starts to fire, the patient can go into atrial fibrillation. That's why a lot of people will get AFib if they drink something cold, or if they, swallow a big bite of a sandwich, or if they jump into a pool.
Hmm.
It is a lot of times people will say, "Yeah, I know I'm going to get my AFib because at first I start to get crampy in my belly, and then my heart will go crazy." So,
Interesting.
there's a lot that we don't know about, but that's why I say it's not a disease as much as it is a symptom, and and as such, it can be caused by a whole host of different pathology and conditions that can lead to AFib.
We have a great question here, and I really like it because with my audience, I found what drives them crazy is not the AFib, it's the ectopic beats. Quite often, it's the ectopic beats, right? And so, can you expect to be free of palpitations after an ablation? I've had two, and I still bouts of high pulses, or just ectopic beats in general after an ablation.
Yeah, I mean, most of the time, if you have an atrial fibrillation, I'm assuming it's an AFib ablation. Then what they most likely did was pulmonary vein isolation. And once you do the pulmonary vein isolation, the AFib foci in the pulmonary veins, can't cause AFib, but you can still have extra beats from other places in the heart, from
Right.
an atrial spot in the right side. You can have ventricular premature beats, or PVCs, which can drive a lot of people crazy.
Hmm.
And unless you're having like thousands and thousands of extra beats all day long, it's very difficult to, be able to send someone for an ablation. I mean, to
Right.
ablate PACs it's like looking for a needle in a haystack.
Yeah.
So, unfortunately, sometimes you have to rely on antiarrhythmic drugs even after an ablation to kind of, relieve the symptoms.
Speaking of post ablation, one of my problems, and I'm not asking you to diagnose me, okay? But at night, my pulse will actually get down to like 33 in my sleep. So I am told that quite often after ablation, people find a new higher resting heart rate. Is that true? Does that tend to happen for people
Yeah,
with low heart rates?
I wouldn't count on it.
Okay.
Now, the question is, why is your heart slow? And it can be just normal.
Yeah, I
Um,
mean, I'm on the tiniest, babyest dose of metoprolol, and the reason I'm on that because if I'm on this tiny flecainide, and if I'm not on the metoprolol, I tend to go into atrial flutter. So
yeah.
they're given the bare minimum of everything
Mhm.
because of the low heart rate.
In
So,
reality, you're asleep when your heart is slow like that. So it doesn't
yeah,
have any physiologic consequences.
yeah,
Um,
okay.
but the one thing you do
Like
have to
right
make
now,
sure.
it's 42 sitting here talking to you.
Yeah. Well, that can be from the beta blocker, and also flecainide can affect sinus node function in people who have underlying sinus node problems. Don't forget, there's this tachycardia bradycardia syndrome,
Okay.
which is just a reflection of the fact that you may have rapid heart rhythm problems because of atrial fibrillation, but the sinus node is often affected at the same time.
Right.
So your heart rate is either too fast or too slow. That's where they get the name tachybrady syndrome.
Right.
I don't.
Yeah.
I wouldn't expect an ablation to improve your bradycardia, but if you do the ablation, you can come off the meds.
Yeah, I
And
guess that's my treatment plan right now is get the ablation to get off the meds.
yeah,
And so because honestly, I'm so AFib free that if I didn't need to come off the meds, they told me probably wouldn't even bother with the ablation,
well,
especially
I
given the waiting list.
let me tell you. All I can say is not to give you medical advice, but you should try to wait for the pulsed electrical field therapy, the
Yeah.
the the pulsed field ablation.
I'm pretty sure we'll get it a few years after it becomes widely used in the US. We tend to let you guys dive into the pool first. Um, Fortunately for me, living in Burlington, right next door is where they'll do the surgery at Hamilton Health Sciences, and it's supposed to be the best in the country. And they're always up on their game. So I'm sure they're as eager to get into that when it becomes available. But I feel like
You
I'd
might,
have to go privately in the States if I was going to be fussy as to the ablation type.
well,
So,
look, in reality, if your symptoms are so infrequent, you can afford to wait. And I would specifically ask your electrophysiologist, "Hey, when can I get, you know,
yeah.
pulsed field ablation? Because I
Well, I
heard it's
see.
safer and more effective."
I see them October, and I will be asking that. Absolutely.
Alrighty.
So, I mean, the nice thing about actually having the waiting list, if there's an upside, it's that I have time to, because they were saying it's almost optional for you. So you at least have time to think about it. So we'll leave you on the list. Let's see how you do for the year. And if you decide you don't want to do it, we're okay with that decision too. So we'll see. Good comment from the audience.
Yeah, I see
Good evening,
Michael's.
Dr. Tullo. I've enjoyed your courses immensely. If you run into a patient with AFib of indeterminate onset and a cardiology follow
Several
up
weeks.
is several weeks away, what do you suggest I do?
Okay, well, a lot of that depends on how old you are and what underlying medical problems you might have, because atrial fibrillation, there's three consequences. Basically, it throws off your rhythm, so you can get palpitations and have a lot of symptoms, which just is very annoying. It can also, the rapid heart rhythm can affect your heart function. So it can not only acutely cause weakness, shortness of breath, exercise intolerance. But if you have a rapid rate for many weeks or months, it can actually weaken the heart. But the most serious consequence is, of course, a stroke, because atrial fibrillation, the presence of AFib, increases the risk of a stroke, especially if you have diabetes or hypertension, or if you're over age 65, or certainly if you've had a prior stroke. So you might want to. I'm assuming that you've seen your regular doctor, and you'd have to have a discussion about whether anticoagulation is appropriate or not. If it is, we'd get onto anticoagulation to prevent a stroke, and then make sure that your heart rate is not excessive, because that's what's going to cause most of the symptoms. If you get your heart rate under control, you can afford to wait a few weeks to see the cardiologist, and then at that point decide if it's appropriate to restore a normal rhythm. And a lot of it depends on your symptoms, your age, your underlying heart problems, and so forth. So, as I said before, the decision-making process is extremely convoluted, and every person is different. So, you kind of, it's not an easy question to answer by any means.
We like to think, we like to think of it as not being in the field, but there's just this flow chart. You ask this question, you see the answer you get, you go to the next bubble in the flow chart. But at some point, I guess the more expertise you gain, the more comfortable you feel going off the flow chart and following your experience. And is it something like that when you're working one-on-one with a patient?
Yeah, exactly. I see there's a response there that Michael starts them on apixaban.
Let's check it out. Let's see. I do H&Ps in a prison. You can translate H&P for me. And the
history
patients
and physical.
Okay.
History and physical.
Okay. And the patients have had no or little primary care prior to my assessment. I usually start them on apixaban, pending an echo, and further cardiology follow-up.
Yeah, I think that's appropriate. I think that's appropriate. Apixaban, which is, very effective in reducing stroke in AFib patients. But, getting an echo and seeing a cardiologist is certainly appropriate.
Yeah. Yeah. No, that's great.
Yeah.
One thing that stood out to me when I read your about page is the fainting aspect, because that's actually an area that hasn't come up on my channel. So is there an association with all arrhythmias and fainting, or just specific ones, or
no,
how does that play out?
Arrhythmias are an infrequent cause of fainting. Maybe only 10 or 15% of fainting spells are due to a primary arrhythmia. So most of the time fainting is due to something else. And, I mentioned I was, and during my residency, I was working in the ICU for quite a while. One of the things that we used to do is take care of the fainting patients. They were admitted and put on a monitor, and we watched them for like 2-3 days. And assuming nothing happened, we just kind of like did a cardiac evaluation with an echo and so forth, and then sent them home. But it's much more of a science now, and I consider myself an expert in fainting. In fact, in New Jersey, I created the New Jersey Center for Fainting, and that I do consults in the hospital and in office for people who have frequent problems with fainting and have struggled with that problem.
Are there degrees of fainting, or we always imagined people just drop and they're out cold? But are there degrees? Or?
Oh, yeah. The final common pathway of a faint, and what most people don't realize, is fainting occurs when there's not enough blood getting to your brain.
Okay.
Because hundreds of millions of brain cells are all talking to each other, and it's, sending messages, chemical messages, and it uses up an enormous amount of energy. And in order for your brain to continue functioning, it has to have a continuous flow of blood to deliver oxygen and nutrients. So it only takes 6 seconds for someone to lose consciousness completely if blood flow to your brain stops. Now, if it occurs suddenly, people will just like fall over. But maybe it's a decrease that occurs slowly. So people will sometimes feel lightheaded. They'll get hot, sweaty, nauseated. So they're like a warning signs in most patients, before they faint, and they kind of know something's wrong before they go down. And if they understand the whole concept, they know to lie down, put their feet up, turn themselves upside down, basically to put gravity on their side. And
Yeah.
that's usually enough to prevent loss of consciousness in most patients.
Interesting. Interesting. So when you started this center and you started studying these patients heavily, what new insights did your center come up with?
Well, it's more of a center of excellence, in that people can come and I can assess, again, you know, what do they say, that what are the three most important things about real estate, right?
Location, location, location.
Right. And my job is history, history, history.
Right.
So you can almost make the diagnosis 90% of the time just from the history, the circumstances, how many times it happened, what they were doing at the time, what medications they're on, and then just looking at blood pressures, lying and standing, and kind of assessing what the underlying cardiac function is. So there's a lot to it. I spend an hour with these patients to try to get an idea of what's happening, and sometimes we can't tell just from the story, because a lot of times they're unconscious, so they can't tell you what it was happening at the time.
Right.
So then we have to do some provocative testing. Sometimes we stand people up for half an hour. We do what's called a tilt table test.
Yeah.
Um,
Yeah.
Sometimes we'll have them wear a monitor. We actually have these little tiny implantable monitors. They're like little paperclip sized chips that get inserted under the skin. And those are extremely useful in people who have infrequent symptoms. So someone
Right.
who passes out once every 6 months, I mean, they can't wear a monitor for six
Is that the
months,
loop
but
recorder? Is that what they call the loop
yeah, an
recorder? Yeah.
implantable loop recorder, right? An ILR or an implantable cardiac monitor. And it takes like 5 minutes to put one in. The batteries last 3 or 4 years, and they're invaluable in diagnosing arrhythmias that occur once, in a blue moon.
Right.
So,
Wow.
but sometimes you'll find that the rhythm is normal at the time of the faint, and it's all about blood pressure, and sometimes something else. So it is a little bit of a Sherlock Holmesy kind of a thing, and I enjoy it. I love it.
I can see why you like it. I mean, it's a real troubleshooting process. I
Yeah,
totally understand why you like it.
and I'm
Let's
a
hear
super
from.
logical guy, so I love sort of like pursuing,
Yeah.
you know.
Well, I mean, your resume shows that you have your hands in so many different things, and it is obviously you're into the technology of both medicine and as a hobby and in your music. Let's see, Corey here. Corey's a longtime follower, and the guy's just plagued with palpitations. He gets them after coughing and sneezing. Even so, they can't be anxiety. Does is coughing and sneeze? Let me read that again. Let me read that. Make sure.
I,
I get heart fluttering and palpitations after coughing and sneezing. Even so, that can't be anxiety. Does the doctor have an idea about that?
Well, I never say that palpitations are from anxiety. Okay. Palpitations are almost always some kind of arrhythmia. Now, what does that mean? How is it related to anxiety? Well, if somebody gets anxious, usually adrenaline gets released. Adrenaline or epinephrine can tickle the cells in the heart. And if you have cells that are prone to firing that give rise to premature beats or arrhythmias, then that anxiety induced adrenaline might make your arrhythmia occur more vividly or avidly, and so it's not the anxiety that causes the palpitations, but that can trigger an arrhythmia. So what
Right.
what what could it be? I mean, premature beats are very, very common, and as I said, sometimes the nervous system, when you're coughing or sneezing, activates some adrenaline because your body sort of like gets jarred, and that can actually sort of precipitate some premature beats as well.
Coming back to the idea of history, history, history. Right? Is
Mhm.
is is this when I hear the term personalized medicine? Aren't we just coming full circle back to getting someone's full history? Is that what we're doing with this personalized medicine?
Well, in the good old days, that's all doctors had to rely on. The history, physical listening with a stethoscope. They didn't have all these fancy testing gadgets, echoes, and cardiac MRIs and things like that. So they relied upon history, but unfortunately, it is a lost art, as I mentioned. And I'm always trying to pull the residents into well, did you ask them about this? What happened before then? What happened after then?
Right.
So the that's part of the learning process in medicine. And, hopefully when people graduate and go on to practice, they'll remember those lessons and, use it in their practice. But not everybody does. Not everybody wants to take the time.
That's true.
It is
Corey
very time
says,
consuming.
Corey, thanks you very much, doctor. He says you make a lot of sense. So thank you, Corey. It's good feedback. Doctor, I could go on for another hour about the feigning thing, to be honest, but we've been on an hour and 10 minutes now, and you've been so generous with your time. And I just want to say that just dealing with you in the emails and the show prep, you've been so gracious with your time, and you're clearly an expert in your field. And I'm so thrilled to have you join us today and share your time and expertise with us. And I hope that, a few people go enroll in your course instead of, and the answers are there for you people. You can learn to read your basic ECGs and get some value out of your watch, because I always find the Apple computer guesses wrong anyway. So I would just like to ask you if you have any sort of closing advice I like to say for that new AFibber who doesn't know where to go, but I mean, that's what I would ask for a patient who's been down that road. What do you have advice for just my AFib peeps in general?
As I said before, the AFib is so variable in different patients. It occurs for different reasons, and anyone who sort of treats the patient with a kind of a boilerplate approach, or one size fits all, is not doing the patient a service. But researching, you could watch some YouTube videos. Keep in mind, a lot of them are just kind of like opinions, so take it all with a big grain of salt. But
Yeah,
when you go to your doctor, be familiar with the terminology that he may throw out at you. Like, well, you have ectopic activity,
yeah,
and those. So go prepared. Don't expect the doctor to give you like a half-hour lesson in the physiology like I do.
yeah, yeah. I mean,
I,
my experience with that is because I actually log into my hospital and read my reports. I'm
uh-huh.
able to do that. And at first, I wonder how the doctor's going to take it when I say, "But what about where it said this and this my report that you never thought I would even see?" And they actually love that. They're actually thrilled by that I'm taking
Mhm.
charge and getting in there. A few comments. Dr. Nick, you are a rock star, from Michael Swartz. Thank you, Michael. He's actually also a rock musician, so that's applicable. Thank you, Corey. Always new information on your channel. Yeah, we try to please. Who knew I could do a year on YouTube just talking about my AFib? I mean, who knew, right? Steve from the AFib Patient Experience. He's another big AFib channel. Maybe I should introduce you if you want to make the rounds, Doctor. And thank you, guys, Doctor. Lucinda is a retired MD in Toronto, and now she helps people sleep better. And we're having her on the show soon. So thank you very much, Linda. Much appreciated. Thank you for such an open-hearted presentation. Thank you, Linda.
Well, let me
Great.
thank you for having me on the show, because it was fun and I really enjoy talking. As you can see, it's the New Jersey in me, what I'm talking about.
Yeah.
So,
No, I would. You have an open invitation to come back anytime.
yeah.
And there's a few people I might introduce you to if you're interested in sort of making the rounds. I have another doctor in mind, actually, I can introduce you to, who's done the podcast circuit for a long time. Because I think you need to get out there, man. I think if you're ready for it, I think the world's ready for Dr. Nick, more Dr. Nick, just based on the reaction I'm getting here.
Well, thank you so much.
Yeah, you could have a fifth career.
Thank you. Well, Joe, you can never have too many, huh?
Yeah. Well, everyone, thank you so much for spending your Saturday night with Dr. Nick and I. The show will be up online forever. And we're so glad to have you all here. It's been a wonderful show. We've had lots of comments in the chat, and we've had this wonderful guest. And I hope you come back. Maybe I'm going to start panel shows soon, so maybe you'd like to come back for a panel show and really mix it up with a few other guests. We'd love to have you for that. So I hope we stay in touch, Dr. Nick. And I'm going to play us out with a little music, as is my tradition.
Okay.
Thanks, everyone, for tuning in. And Big Northern Bear, out.